Good morning, friends. At the outset, I am really thankful to the organizers for providing me this opportunity to share my thoughts regarding this important topic, that is the circadian rhythm and the sleep disturbances in patients with bipolar disorder. In next 40 minutes or so, we will discuss about the basics of the sleep and the wakefulness. We will in brief discuss the neurobiology of bipolar affective disorders. We will look at the observations regarding the sleep and the circadian rhythm in patients with bipolar disorder. We will look at the physiological underpinnings of the findings, and we will try to see if the changes in the sleep duration and the circadian rhythm they bring any change in the symptoms of the bipolar disorder. Then I'll just simply give a passing remarks on the other sleep disorders which are commonly seen in patients with bipolar disorder, and then I'll summarize my presentation. The data which have been taken in this presentation is taken by the patients themselves. Some of the studies have used the gene knockout mice, and other studies have used the expression of the circadian genes in the fibroblasts of the cells taken from the patients with bipolar disorder. Coming to the basics, so first we will discuss about the sleep and wake regulation. So as you can see here, sleep and the wakefulness, it is basically governed by two different sets of nuclei. Ascending reticular activating system, which promotes the wakefulness and the alertness, and the ventrolateral preoptic area, which promotes the sleepiness. Now, when we are awake and alert, this ARAS sends inhibitory signals to the VLPO so that we stay alert and awake. But in the night, when we fall asleep, the VLPO sends GABAergic signals to the neurons present in the ascending reticular activating system, and that is the time when we fall asleep. Sleep in our daily routine is regulated by two different processes. One is the circadian process, as you can see here, which is basically regulated by the suprachiasmatic nucleus and secretion of the melatonin. And second is the homeostatic process, which is basically regulated by the sleep pressure. Sleep pressure increases with the duration of wakefulness. So longer we are awake, higher the sleep pressure, and when it reaches a critical limit, and when the circadian rhythm also favors us falling asleep, it is that time when we actually fall asleep. In the morning, when the circadian time promotes the wakefulness, as well as the sleep pressure is minimum, it is the time when we wake up. If we look at the suprachiasmatic nucleus, this is basically known as the master circadian clock. The reason is the circadian genes are not only expressed in the suprachiasmatic nucleus, but the similar kind of biological clock is also present in other areas of the brain as well as in other organs of the body. So almost every cell of the body, it contains the a molecular biological clock, but the activity of these peripheral clock are regulated by the suprachiasmatic nucleus through the secretion of melatonin, and that is the reason the suprachiasmatic nucleus is known as the master clock. This is one of these cells which is present in the suprachiasmatic nucleus or any other organ of the body. In the nuclei of the cell, we know that there is DNA, and DNA is composed of different kinds of genes. So these are basically the genes which are important for the circadian clock. And this circadian clock function in a transcription and translational feedback loop. So it starts with the transcription of BMAL and the clock, which after the transcription, they say turn into a transcription factor, which gets attached with the E box of the other clock genes, and it thus regulates the expression of these other gene. When these other genes they express, they first go the transcription and then translation, and their product is then released in the cytoplasm. Among these two per and cry are important because this dimer, it when it translocates to the cytoplasm, it gets degraded by the activity of the casein kinase epsilon 1, and when this their concentration in the cytoplasm reaches to a critical level, then it actually goes inside the nuclei, and inside the nucleus it regulates the expression of the BMAL and the clock gene, and this is how the 24-hour rhythm is being maintained. We all know that the circadian clock, if it is expressed on itself, its duration is slightly longer than 24 hours in humans, but it gets entrained every day with the circadian timing, that is the 24 hours timing, and light is the strongest zeitgeber. But besides light, there are number of other factors which also helps us to entrain this clock, and among these are sleep wake cycle, social cues, time of the food intake, time of the exercise, and many others. So we can say that the circadian clock is not only running on its own, but it is also being regulated by our behavior and the environmental stimuli. How to measure the circadian rhythms? In the laboratory, we can measure the circadian rhythm with the help of dim light melatonin onset as well as measuring the temperature rhythm. But how to measure the circadian rhythm outside the laboratory? If we want an objective parameter, then we can use the actigraphy. Actigraphy is a small watch-like instrument which basically measures the activity, and this 24-hour activity is considered to be representative of sleep and the wakefulness. Then there are certain self-rated scales which measures either the chronotype. Chronotype means the people whether they prefer morning awakening early in the morning and going back early in the night, that is whether they are morning type, or whether the people are evening type. Evening type are the people who prefer to go to bed late in the night and to wake up late in the morning. And in between those two, there are most of the people who are of intermediate type who can go to either side depending upon the circumstances. Then amplitude and the stability of the rhythms can be measured by circadian type inventory, and this one scale brain, it is observer rated, and it provides a good idea about the circadian preference of a person. If we look at the neurobiology of the bipolar disorder, so these are the important areas which are basically important for the various kind of symptoms which appear in the patients with bipolar disorder. So what the neurofunctional imaging studies have shown that the dorsal anterior cingulate sulcus, dorsomedial prefrontal cortex, and the dorsolateral prefrontal cortex are the three areas which are basically associated with the cognition, decision making, motivation. These are basically hypofunctional in patients with bipolar disorder. And the ventrolateral prefrontal cortex, ventral anterior cingulate cortex, and the amygdala, the areas which are basically important for regulation of emotions, these are hyperfunctional. Going from a macrostructural level to the cellular level, the neuroglia, they are also important for the symptoms of the bipolar disorder, and their functioning, it alters during the acute symptomatic phase. So what has been found that in bipolar disorder patients, the astrocytes, they undergo a number of changes. For example, this is basically based on the neuroinflammatory theory of bipolar disorder, which suggests that bipolar disorder is in a state of a heightened inflammatory function. So these peripheral inflammatory markers, when they reach the brain, they are sensed by the microglia. Microglia become activated, and then they activate the astrocytes. Once they activate the astrocytes, then in turn the astrocytes, they also release the cytokines, which actually further activates the microglia. So this becomes a kind of feedback loop where both the cells, they are increasing the activity of each other. After that, there is a reduction in the blood brain barrier, because the astrocytes, they lose their support to the blood brain barrier, and it becomes more permeable to the inflammatory markers. The astrocytes, which are having an important function of uptake of the glutamate, which is an excitotoxic neurotransmitter, this is also affected, and instead of uptaking the glutamate in the synapse, they start releasing the glutamate, leading to the neuronal injury. In addition, the GABA, which is basically inhibitory neurotransmitters, its release is reduced, so that all the cells which form the glial cells, they become hyperfunctional, as well as the astrocytes, they also reduce the secretion of the BDNF and the GDNF, two important neurotropic factors which are important for the maintenance of the cells as well as the neurogenesis. So that leads to a kind of inflammatory states in the brain. Now let's try to examine some of the observations. During the bipolar disorder acute episode, the sleep disturbances, they appear prior to onset of the acute episode, and here they are known as the prodrome symptoms of the bipolar episode. During the acute phase, sleep disturbance, they increase, but with the treatment they start reducing, and they improve by the end of the resolution of the acute episode. But even during the remission stage, a number of patients, they show the sleep disturbance, and here the sleep disturbance is considered a risk factor, which actually increases the chances for the reoccurrence of the bipolar disorder. If we talk about the circadian rhythm disturbances, they are seen throughout the course of bipolar disorder, both during the symptomatic stage as well as the remission stage. The studies have shown that the sleep disturbances, they actually antecedate that of bipolar disorder. They may start during the adolescence, and they antecedate the acute episodes by 1 to 12 months. Studies have also shown that offsprings of patients with bipolar disorder, they report sleep disturbances more frequently compared to the offsprings of controls. And these offsprings, they have an unstable rest activity cycle, suggesting a circadian rhythm dysfunction. If we try to look at the prodrome of the sleep disturbance and we try to correlate it with the polarity, it has been found that reduced need for the sleep during the prodrome, it antecedates the manic episode. Insomnia, it harbinger the depressive as well as the manic episode, and the hypersomnia during the prodrome, actually it appears well before the depressive episode of bipolar disorder, but not of unipolar disorder. And this hypersomnia reliably differentiates the bipolar depressive episode with unipolar depressive episode, with a positive predictive value of nearly 70%. Even during the remission phase, the patients with bipolar disorder, they show a number of problems. For example, their total sleep time is increased. They report multiple nocturnal awakenings. Sleep efficiency is reduced. Variability in the pattern is seen. Variability in duration is seen. And very importantly, the sleep disturbances during the episode, they increase the risk for the suicide. So they should be taken seriously and be managed. Now, this graph shows what does the actigraphy studies show about the different mood disorder. So, actigraphy studies show that the wake after sleep onset as well as the sleep onset latency is longer in the patients of depression compared to controls. The total sleep time is lesser as well as the sleep efficiency is lesser in euthymic uh, in controls compared to the euthymic bipolar disorder. The frequent nocturnal awakenings as well as sleep onset latency is increased in mania compared to the controls, as well as before the treatment of depression in patients compared to after the treatment of depression. If we look at the circadian rhythm problems in the bipolar disorder, so these are the data shown from the at-risk participants, and at-risk participant means the participants who are the offsprings of the bipolar disorder. So naturally they are at high risk of development of bipolar disorder, or the patients who are having sub-threshold features of bipolar disorder. What has been shown that the patients, the at-risk participants of the bipolar disorder, they show heightened activity when they go to bed. So their sleep onset latency is increased. They show variable number of awakenings in the night, and their overall activity is lesser compared to that of control. So we can see that the relative amplitude which is normal in the healthy control, it is reduced in the at-risk participants. The circadian rhythms, as we have earlier discussed, they are actually have a two-way communication with the social rhythm as well as reward. So all these three factors, they regulate each other, and that is the reason the patients with the depression as well as mania who have dysfunctional reward perception, they have a changes in the circadian rhythm as well as social rhythms as well. In other words, we can say if we modify one of these factors, it can lead to a slight change in the other type of other two functions. The high risk group of the bipolar disorder, for example, who are the familial cases, they show that sleep is more variable in duration. In the prodromal phase, their activity is delayed and the sleep fragmentation is seen. Rhythms have the lower relative amplitude. Social rhythms are variable and irregular. Hyperthymic people, they usually have morning chronotype, while the cyclothymic or the irritable people, they usually have the evening chronotype. Now, if we look at the circadian disruption that occurs over the course of illness, then you can see that irregular social rhythm precedes the first episode of mania in bipolar disorder 1 and first episode of depression in bipolar type 2. Hypersomnia and anergia, they suggest conversion of bipolar disorder to major depressive disorder. And the patients who are having delayed sleep wake phase disorder, that means who go to bed late in the night and who wake up late in the morning, they are at high risk of the earliest onset of bipolar disorder. They show a greater amount of the suicidal behavior. They suffer the risk of recurrence of bipolar disorder, and they are at risk of manic switch when they are prescribed antidepressants. Candidate gene studies from the knockout gene mice have shown that methylation of the BMAL1 is associated with the bipolar affective disorder. Variants in the clock gene, they are associated with the propensity to develop bipolar disorder. One of the per gene, per actually has three different genotypes, the per1, per2 and per3. So per3 is associated with the functioning of the per is associated with the functioning of the reward circuit, and the variants in the per3, they are associated with the age of the onset of bipolar disorder, postpartum onset of the bipolar disorder, as well as seasonal affective disorder. Cry protein expression in the nucleus accumbens, it is associated with the feeling of helplessness, which is commonly seen in patients with depression. And stability of rever alpha, it is associated with the responsiveness of the lithium. So if a patient is having stable rever alpha, then he is having greater chances to show response to the lithium therapy. Uh, Now, single gene nucleotide polymorphism studies, they are actually suffer from a major problem that they ignore the effect of the other SNPs. To overcome this, the GWAS studies or the genome-wide association studies have been done, and the GWAS studies have shown that risk of the bipolar disorder is associated with the reduced morningness, and it is a unidirectional association. That means the reduced morningness increases the risk of bipolar disorder, but bipolar disorder does not increases the risk for reduced morningness. And the total sleep time, which is a bidirectional risk, that means reduction in the total sleep time increases the risk of bipolar disorder, and bipolar disorder also reduces the total sleep time. Polygenic risk scores, which can be derived from the GWAS to estimate the aggregate risk from multiple SNPs, they have shown that low relative amplitude is associated with bipolar disorder, mood instability, neuroticism like anxiety, major depressive disorder. So this reduced relative amplitude is not very pathognomic of bipolar disorder. It is seen across a range of psychiatric disorder. Long sleep duration increases the risk for bipolar disorder type 1, and insomnia increases the risk for bipolar type 2. If we look at the circadian rhythm disruption in bipolar disorder, based on the circadian disruption, a number of phenotypes have been found. So, one of the phenotype are the people who respond to the lithium versus who do not respond to lithium. So people who respond to lithium, they have higher morningness. That means the people who are LARC type, they are more likely to respond to the lithium. The people who are having shorter circadian period, they are likely to respond to the lithium. People who are having lower amplitude of the circadian rhythm, they are likely to respond to the lithium. Another phenotype is the seasonality, whether the bipolar episodes they occur with the season. So bipolar 2 people are more likely to show this seasonal affective disorder, and this is associated with the variants of these three clock genes. Environmental influences also regulate the sensitivity to the bipolar disorder. A person who is excessively sensitive to the melatonin suppression by light is more likely to develop bipolar disorder, and it is one of the biomarkers for the bipolar disorder. Some of the studies have shown that people who are exposed to the longer daylight at their birth, they have delayed onset of bipolar affective disorder. And the people who are having a longer daylight at birth, they are more likely to develop bipolar 1 disorder, and they have a family history of bipolar disorder. Lithium has also been included with the circadian rhythm. It has been found that lithium shifts the biological clock towards the morningness, which is in bipolar disorder shifts towards the eveningness. Fibroblasts of the lithium responder show shorter circadian cycle length. Lithium further induces the shortening of the circadian cycle, and it increases the amplitude of the circadian cycle. So we can conclude that lithium actually increases the amplitude of circadian rest activity rhythm, and the morningness may be associated with the response to the lithium, but this is the preliminary data, and further research is required for this to become a fact. consider the physiological underpinnings, we have seen that astrocytes are present in the brain, and these astrocytes are important for the sleep as well. These astrocytes, they actually express the clock genes, especially those which are present in the suprachiasmatic nucleus. And through this expression of clock gene, uh, which affect the other clock regulated genes, so the expression of the different kinds of neurotransmitters like glutamate and the GABA, it also follows the circadian cycle. And by regulating the glutamate level in the suprachiasmatic nucleus, these astrocytes, they keep tab on the timing. These astrocytes, they are also important for the homeostatic process, because homeostatic process or the sleep pressure is regulated by the adenosine, and higher the level of adenosine, greater the sleep pressure, greater the chances to fall asleep. So, if the astrocytes are not present in the brain, the adenosine will be depleted from the brain and this homeostatic pressure will be lost. And these astrocytes also help cleaning the brain parenchyma. It has been found that the astrocytes in the patients with bipolar disorder, they go a major change. Uh, they show the asthenia and the atrophy in the prefrontal cortex, in the anterior cingulate cortex, in the orbitofrontal cortex, and in the amygdala and the hippocampus. They are reduced in the number, and their neurotransmission is also altered, which actually alters the circadian rhythm as well as sleep wake cycle as well as sleep wake state. We have earlier discussed that suprachiasmatic nucleus is the master regulator or the master clock of the body, but other areas of the brain which are important for the expression of the symptoms of the bipolar disorder, like prefrontal cortex, nucleus accumbens, hippocampus, habenula, amygdala, and the ascending reticular activating system, they also show have the circadian cycle, and their activity varies with the circadian rhythm, and that is the reason that they show differential activity according to the circadian cycles. And when this connection regulation from the suprachiasmatic nucleus is lost, as we see in the bipolar disorder, their activity go haywire and the symptoms of bipolar disorder may appear. Moreover, some of the areas of the ascending reticular activating system, they are also important for the state of wakefulness. So this also shows why the sleep disorders are common in patients suffering from bipolar disorder or other psychiatric disorder. We have earlier discussed that the bipolar disorder is associated with the altered functioning of the dorsolateral prefrontal cortex, orbitofrontal cortex, medial prefrontal cortex, anterior cingulate cortex, and these are the areas which are important for the cognition, emotion, decision making, and motivation. And in these areas, the circadian dysregulation of the expression of the clock genes, especially the PER1, PER2, BMAL, and REVERV alpha, has been found in the post-mortem studies. Similarly, same kind of changes have been observed in the hippocampus, amygdala, and the anterior cingulate cortex, which again regulate the emotional part of the bipolar affective disorder. Uh, Areas which are important for the reward circuit, that means the ventral tegmental area to the nucleus accumbens, amygdala, and the prefrontal cortex, they are regulated basically by the dopamine, and a circadian variation is seen in the synthesis, release, postsynaptic action, degradation, as well as the firing pattern of dopaminergic neurons. The genes which regulate the tyrosine hydroxylase, which is an important enzyme for the synthesis of the dopamine, is regulated by the clock genes. MAO-A helps in degradation of the dopamine. It is also regulated by the clock genes. Dopamine receptors genes, they also undergo a circadian variation, and in clock genes knockout mice, all these they show altered activity. Furthermore, the suprachiasmatic nucleus, it is gets entrained through the through the dopamine by the D1 receptors. So when the dopamine is less, the entrainment is also lost. So it's basically a problem which is occurring bilaterally. Similar to dopamine, the serotonin synthesis as well as the receptors of the serotonin, which are important for the entrainment of the suprachiasmatic nucleus, they also go diurnal variation, and that is another finding which suggests that the circadian rhythm and the bipolar disorder, they are linked. Now, what happens if we manipulate the sleep and the circadian rhythm? Does it improve the symptoms of the bipolar disorder? Chronotherapy basically tries to shift the sleep-wake cycle. We can influence the sleep-wake cycle by altering the exposure to the Z-Zabers, by altering the cellular clock, which can be altered by the intrinsic as well as extrinsic factor like social factors. We know that other parts of the brain as well as other body parts, they also express the clock. So if we are making any kind of change in the central clock, it will also affect the peripheral clocks, as well as the different kinds of areas of the brain. They are important for expression of different kinds of behavior like sleep wake cycle, for the activity, social activity, the food intake, and these behavior, they also entrain the suprachiasmatic nucleus. So if we bring any kind of behavioral change, it will definitely entrain the suprachiasmatic nucleus and will change the circadian rhythm. Sleep deprivation, or in other words, we can see the total sleep deprivation of 36 hours has been shown to improve the depression in 6 to 48 hours in nearly 80% of the patients. Patients who are having endogenous depression, they are twice more likely to respond to the sleep deprivation than that of the neurotic depression. Patients who are having diurnal variation in mood, they are more likely to respond to the sleep deprivation. Patients who are having low sympathetic activity are more likely to respond to sleep deprivation. Similarly, high thyroid function and altered dexamethasone suppression test is also more likely to indicate that the patients are at greater chances of responding to total sleep deprivation. Similarly, patients with unipolar depression are more likely to respond to total sleep deprivation compared to patients with the bipolar depression. But the major problem is when these patients, they undergo recovery sleep, the antidepressant effects terminate in nearly 80%. To sustain the antidepressant effect, what we can do? We can add either the medication or we can use the chronotherapy. Studies have found that when the total sleep deprivation was added with the medication, after the 3 cycles of the total sleep deprivation, good response was seen within a week. When the total sleep deprivation was given initially and the medications were added on day 10, then it was found that the good response was seen acutely in the depression, and the response was sustained till 3 months. If we talk about the tolerability and the induced mania by the total sleep deprivation, there was no difference across the groups who were given total sleep deprivation and those who were not given the total sleep deprivation. Chronotherapies means the therapies which shift the circadian rhythm, and we can have two different kind of therapies. One is the exposure of the patient to the bright light or the dark therapy. It has been found that the bright light therapy for the depression, unipolar or bipolar, is as effective as antidepressants, and patients who have been exposed to the morning sunlight, they have been shown to have reduced hospital stay for the depression. That means they responded faster than the patients who were not exposed to the morning sunlight. Dark therapy in the manic patient reduced the hospital stay. If we if we look at the other kind of chronotherapies, that is the interpersonal and social rhythm therapy, which aims at improving the interpersonal functioning, reinstating the social rhythm, and focuses on the medication adherence, it has been found in a meta-analysis to improve the functioning in the patients with bipolar disorder. However, it does not have any effect on the symptoms of the bipolar disorder, so it has been suggested as an adjuvant therapy. But the only issue in this meta-analysis was the small number of trials, so we need further research before we say that IPSRT is whether effective or ineffective. Another form of chronotherapy that can be given is the ingestion of the remeltion, which is a melatonin agonist. So one meta-analysis, it included the 3 double-blind RCTs. Patients were suffering from bipolar disorder. They were on medications, that means the antipsychotics and the mood stabilizers. They were given the remeltion 8 mg per day for 8 to 12 weeks. Another group was given placebo, and the result shows that relapse due to depression was prevented, but not the relapse due to mania or hypomania or that of mixed episode. Moreover, the patients who were given remeltion versus those who were given placebo, they were not different with regards to the sleep quality at the end point. A number of studies have suggested that medication, all the mood stabilizers like lithium, valproate, carbamazepine, and tricyclics antidepressants, they change the length of the cycle. When they shorten the length of the cycle, they have antidepressant effect. When they lengthen the cycle length, then they show the anti-manic effect. But the evidence is preliminary. Now there are certain other issues. So far, the circadian disruption is considered one of the biotypes of the bipolar affective disorder, because circadian disruption is seen not only in the patients with bipolar disorder but also the patients with major depressive disorder and schizophrenia. But another issue is that when we are diagnosing the bipolar disorder, then it has multiple phenotypes and the patients have not been classified according to those phenotypes. So there is a possibility then if we do the study by taking a particular phenotype, we can find out that the chronotherapy works in one of the phenotypes but not in others. Considering the other sleep disorders that are seen in bipolar disorder, this is one of the recent study which has shown that obstructive sleep apnea affects more than 50% of the patients with major depressive disorder, bipolar disorder, schizophrenia, and somatic symptom disorder. Unfortunately, we do not diagnose this obstructive sleep apnea, and that is how we delay the response to the medication to these patients. Insomnia influences nearly 1/5 of the patients with bipolar affective disorder. Nearly 1/10 of the patient they report hypersomnia, restless leg syndrome, and REM sleep behavior disorder. And unfortunately, because our paucity of the awareness regarding the sleep disorder amongst us, the psychiatrists, most of these they go unnoticed. So in summary, what we can say that sleep and mood, they are interdependent. Biological links are known both in terms of the functional areas of the brain as well as the genotypes. Clock genes, they affect the mood as well as cognition as well as the behavior, as has been shown in number of knockout gene mice studies. Behavioral measures, that means alteration of the Z-Zabers, also alter the expression of clock gene through entrainment of the suprachiasmatic nucleus. Mood stabilizers and antidepressants, they also alter the expression of the clock gene, and they also influence the amplitude as well as the length of the circadian cycle. Sleep disorders are prevalent in bipolar affective disorder, and hence the disturbed sleep should not be considered just as a symptom of a bipolar disorder, whether manic phase or the depressive phase, and should be given due consideration. Thank you very much once again for your patient listening. Thank you.